On this segment, we'll want to address some of the perception issues and ways to deal with children and their parents in terms, in your roles, in my role as a provider, in the parent role as the parent, and as the teacher, school psychologist, and counselor, in terms of dealing with the diagnoses that they're being treated for and the medications. And again, it's understandable and probably appropriate that there's a lot of emotional charge that comes with the idea somehow of affecting a child's nervous system, the way they look at the world, their behaviors. As a matter of fact, it sometimes shakes me up a little bit, and it becomes almost spooky when I have a child that I saw in my office. I was just about to hospitalize. He had bipolar disorder, and you know, he was just cursing and spitting, and his mother was just in tears. She'd never kind of seen him like that. It was just beside himself. It was hard to describe just how violent that behavior was. I was on the floor with him after a while, holding him. We kind of went down to the floor just to kind of restrain him. And I was getting ready to call the hospital, and I said, well, this was late in the afternoon. I said, look, he finally calmed down enough to sit in a chair, but he was still very abusive and in ways that his mother had never seen him. I was wondering that even at age 11, had he been using some substances and stuff, and once we kind of worked out that that was not the case, we had him take a bolus, about a 10 milligram tablet of Abilify. And I'm telling you, now it usually may not be this dramatic in a few minutes, but generally it tends to be potentially that dramatic within a day or so. That night, he said, Mom, I can't believe that I said those things. I'm really sorry. And Dr. Hardaway, golly, I'm sorry that I did that. Did I do that to your glasses? And I said, well, don't worry about that. But I mean, he was rational, and he was his usual kind and empathic self, and calm. It was this was a Dr. Jekyll and Mr. Hyde experience, but to see the medication do that, or to have parents come back who've had this history of just this total out of control agitation, throwing furniture in the classroom, attacking people and the like, and you put them on a milligram at night of Risperdal, and you come back and the teacher says, I love teaching him, he's really, I didn't even know he was this kind of kid, and he's sitting there involved in the classroom experience, working well with peers and the like. And to me, that kind of shakes me up. It's almost spooky that when you think about it, we're not changing the child's personality. I like to think that is the real child. And the storm that's enveloping this child, that mask, so to speak, is really pretty not only dysfunctional, it's just darn toxic and tragic. Many times that will not respond to the medications that we want for it to. But when it does, it's very remarkable, and it makes you really wonder how the brain really works, and these medications, how effective they can be. So for that reason, it's understandable that there would be a lot of concerns about the use of psychotropic medications in children. So depending on your role, there's a lot of, I think, obvious misperceptions. First of all, I've got this in your first slide here. Medications will snuff out behaviors that are really a pain, disruptive, or embarrassing. And somehow there's something magic about this medication. The kids are real pain and getting on my nerves. Just give them something and we can just snuff out the behavior and he can be normal. Generally, as we've talked about before, that's not going to be the occasion. Well, you're talking about specific symptoms that are just causing dysfunction, but other things are going on at the same time that a pill will not address. Medications change the brain and personality of the child so he's a better child. The medications should never change one's personality. There may be the perceptions that their personality has changed, And as we talked about in my last example, he'll change from this really out of control, agitated child to a very rational and empathic kid. But that rational, empathic kid is who the real kid was in the first place. It's just hard to understand why he was going through this storm otherwise. Medications will prove that my child is ill and not bad. And unfortunately, many parents come up with that expectation that if you just give him this medication, everybody will know now that my kid's not a bad or evil child, he's just an ill child. Well, that's not really what we're trying to do with the medication. In terms of how the child interacts with the environment, how the child functions in the classroom, and the like, obviously it becomes personal when you're trying to redirect them and they're oppositional and defiant, and it becomes very personal. But in terms of changing somebody's personality, that thank goodness cannot happen. And nobody's ever said that the child was bad, but that's the parent's perception. Frequently they'll just be told, you know, you're not doing a good enough job as a parent, and this really is a bad kid, and he's got a real attitude problem, and you just gotta parent him right. Well, maybe that's true a lot of times, but most of the time I've found that that's not the case. So even if a kid does have a disorder, the idea that he's ill instead of bad is a gross oversimplification of the problem. I try very hard to redirect the parents' understanding that their child is a total of some really wonderful characteristics, some real positive values or resilience, and other things that are like torpedoes that are getting in his way, and that's what we're going to direct the medications at. That medications will eliminate the need for other kinds of interventions. In other words, if you find the right pill, doctor, if you do this just right, I won't have to take him to therapy anymore. I won't have to deal with all that stuff or worry about how he manages behavior and stuff like that. That you just got to find the right pill. You haven't found it yet, but I know you'll find it, and he'll change and be a perfect kid. And so as you can read into that, there's a lot of reframing that has to be done in terms of the parents' perceptions of the role of medications. Some of the other interesting comments that I'll get is, doctor, the teacher says, which usually is not the case, but that's what the parents say, the teacher says he can't come back unless he's on medication. Well, that puts me in a real box, and I have to explain to the parents that we'll do an evaluation and we'll see what the specific problem is, and we'll see whether medication will be helpful, potentially helpful or not. But frequently they either will be told by the teacher that he needs to be on medication, or the parent uses that and comes in and states that. Or, doctor, I don't care what you put her on, she's driving us crazy, just put her on something so she gets out of our hair. That concerns me, and again, there's this kind of idea of a magic pill that will make a child good from having been bad previously. Then some unrealistic expectations. The child is depressed, and if you just give him the medication, then he'll be happy. And as I tell the parents, happiness, it's not going to make him any happier than if he had a burst appendix and the surgeon went in and did surgery, took his inflamed appendix out, and now he's back to baseline. The surgeon didn't make him happy, maybe a little relieved from the pain, but he's not a happy kid yet. That's all up to him, his people who guide him in his life, his teachers and counselor or whatever. That's something he works on throughout his life to be happy. With the depression, as we talked about, he's got dysfunctioning symptoms that are weighing him down, keeping him from functioning, which go hand in hand with his sadness. But we can restore a lot of his function, and the kid may not be happy. That's something, again, that has to be worked out in his therapy and guidance and behavior management and all the other things that he does to make himself happy in terms of accomplishments at school and the like. The doctor, the mood stabilizer isn't working. He still gets angry about things. Well, yeah. He's not going to be a kid who never gets angry again, or doesn't get agitated or anxious or get mad at his little sister or whatever. We're talking about there's no pill to keep you from getting angry. What we use the medications for is in those children who have so much mood instability that when they get agitated or angry, they go out the top, start throwing things, agitated, get way out of control and the like. That's abnormal, that's clinical. And the medications, again, as we talked about before, can help them reorganize their thinking, have better control from that cortex and rational thinking process to take over and help control their own moods. But there's not a pill that's going to keep somebody from being angry. And so that takes some explaining to parents and other people besides the parents sometimes. The sleep medication isn't working. I send him up to bed every night. When I come up there, I find out he's still not in bed. So I tell the parents, you know, there's no medication that's going to chase a child around the house, knock him down and put him in a coma. The medication is there so that as you go through the normal sleep hygiene process of having a routine, maybe some sort of ritual, you turn the lights out, absolutely no electronic devices going on, maybe rubbing his back, saying a story, talking about what's happened during the day, and it's a process that we do have to do with each of our children. I remember being quiet as a father of 2 ADHD kids till the day they graduated from high school. It was kind of a ritual to help them get to sleep. And actually that turned out to be some of my favorite memories, was the talks that we had as they fell asleep. Problem was I was hoping to do something with the rest of my evening, and sometimes as I told stories to my kids, made up some stories, I'd be so tired that the next thing I knew they'd be saying, "Dad, what happened after that? Dad, wake up, tell me what happened." So I'd be so tired at times that I wouldn't get to use the rest of my evening, because sometimes that does take energy from a parent to help your kids get to sleep. But certainly giving them a bunch of clonidine and sending them upstairs to go to bed is not going to guarantee anything in terms of their sleep. There has to be a setup to be lights out, in bed, trying to go to sleep, and then the medications can be helpful. The perceptions, the negative perceptions about medications, such as it'll drug up my child and turn him into a zombie. Well, yeah, sometimes there can be adverse circumstances of a medication, in which case we stop the medication. We don't want him to be like a zombie. We don't want to drug him up or have him sedated during the day. That defeats the purpose of the medication. I'm afraid the medication will just get her used to being dependent on pills to solve her own problems. Well, that simply isn't the case. If you have clinical depression and the Prozac helps you to get rid of some of those target symptoms so that you can function again, that's not the same thing as popping something that'll make you feel temporarily great. That's called medication abuse. But in terms of a rational use of medication, that will not happen. You don't have to worry about that. He won't learn to listen if he uses medications. The school just needs to spank him. It worked for me. And generally I ask the dad who says that, well, how's it working for you? Just like Dr. whatever his name, Oz or Dr. Phil, how's it working for you? Well, he's not working well for him because he's getting in trouble at school and all this kind of stuff. But if they would just spank him, we'd knock it out of him. And so I said, well, it's not that medication's necessarily the answer, but the fact that we're using medications to address his ADHD or whatever as part of an overall program may help to change the dad's perspective on this, and that there's nothing inherently evil about using the medication if it's used correctly. When she stays up, she knows what will happen if she acts up. She wouldn't dare act up with me. When she stays with her mom, she acts up. Pills don't solve that. Well, I agree. If you've got two households that undermine each other by having situations which are not constant, and you've got an inconsistency in discipline, there's a problem. That doesn't have anything to do with whether she ought to be on medication or not, if it's indicated. But those are the kinds of perceptions that people will come up with. And then we've talked about the perception that if he uses medications now, he'll use drugs more as an adolescent later, and generally the fallacy of that. Important considerations before describing any medication. All these perceptions that parents have are understandable. So I'm never indignant that somebody has those perceptions. It's a chance for us to discuss the disorder, and discuss what I found in my evaluation, and discuss where we need to start with the treatment, why I think a medication might be helpful, and as we review the target symptoms and the effect it's having, why we want to stay with that, maybe change the dose, change the medication. So these perceptions, I don't mind the parents having. I feel much more comfortable with a parent who's uncomfortable with medications than a parent who says, put them on anything, doc, just fix them. It's important to get a very careful evaluation, and I'm not going to go into the details that are already in your notes, but the important thing is to make sure that you stand back, take a careful evaluation of the history all the way up through what did that mean when he repeated the first grade. Did they say he had a reading problem, or was it the ADHD issues? And you're trying to sift all that apart to make sure you understand the course of events that have led up to him now being oppositional and defiant, as well as being unsuccessful in the classroom. And so when you come up finally with an assessment, you make a problem list of each of the problems, and sometimes you have then medications that can be helpful in addressing those particular target behaviors. So then when you send a survey or some sort of instrument to the teacher or to the school counselor, it can be more meaningful if you're looking at very specific behaviors, as opposed to, he's got bipolar disorder, I gave him a medication to do away with bipolar disorder, is it working? That's so general, it lends itself to everybody's perceptions. That's not helpful at all in judging whether medication is helpful. So when we're considering the use of these prescriptions, first of all, I never feel as a prescriber that I should put pressure on anybody to utilize any kind of treatment on behalf of their child, whether it's psychotherapy or whether it's medication. Certainly with medication, I tell them why I think the medication would be helpful, how it's supposed to work, what I expect would happen, how we'll follow the course and track it, and then possible side effects and what to let me know about, what things we would do differently, or what things to watch for. Those things are really, really important. But a lot of times, and I think appropriately so, the parents will say, well, we'd like to try the therapy first because we're really uncomfortable with the idea of medications. And I say, well, good. Why don't we plan to have you come back in about 6 weeks? We'll see how things are going. I can tell you right now, the 5-year-old with super duper ADHD with hyperactivity, impulsivity, yes, the guidance is to start with psychosocial interventions, behavioral guidance and the like, but it isn't long before the parents are back and they say, put up the white flag and say, okay, let's talk about the medications. And then even then I'll tell them that with our preschoolers, kindergartners, even first graders, we want to be careful with this, and I share your concerns and worries about that. So I'm equally a little bit concerned about possible side effects that are more frequent at this age. But on the other hand, the only other alternative is not using the medication, which we know can be helpful. And not using the medication means that at this formative time in their life, they're not getting the social education that they need, where that's important to develop empathy, to develop control over one's impulses, to be able to focus on something that's not immediately rewarding, and to stay caught up with everybody else in terms of their basic core academic skills and math skills, reading and the like. And so you're caught between a rock and a hard space, but we go ahead and try the medications for ADHD and generally have a very satisfying and very helpful response that we can't take for granted, but hopefully will occur more frequently than not. In school, in terms of function at school, when you have an ARD, and I know you guys, I'm talking your language now and probably not talking about it very well, but when you have an ARD and you've described and decided that a child meets criteria for ARD services under the eligibility of ED, it's generally because there's been a well-assessed evaluation indicating a specific psychiatric diagnosis, generally severe, like an anxiety disorder, major depressive disorder, bipolar disorder. But just as an ARD service may not be required, it may not need to be on an ARD just because he's got the diagnosis of depression or bipolar disorder, but just as you administer services that address certain behaviors that interfere with their functioning and interfere with their ability to get a normal education, that's what you base your behavioral intervention plan around. You also, though, won't maybe give him any ARD services if in fact he's got the diagnosis, but there aren't any behaviors that interfere with his schooling. In that way, it's similar on the medical side, mental health. Just because you have a particular disorder, it doesn't necessarily mean that we're going to throw all sorts of medications just because on TV it says Abilify used to treat bipolar disorder. You have to explain to the parents and often to teachers and others that we're treating behaviors. The disorder is still there. When we treat a diabetic with insulin, we're not treating the diabetes per se. The diabetes is always going to be there. We're treating the specific phenomenon or behavior that's going on that's keeping them from being functional. So whether that means hallucinations, whether that means sudden agitated and aggressive behaviors, whether that means generalized anxiety to the point where they can't keep their focus on what they're doing because they're so anxious. Those are the specific target symptoms that we're going to be evaluating. And we need the teacher's input, which means that the parents need to share with the teacher. In general, I'll write out an evaluation with my recommendations, not to tell the school how to do its business, or where they should place them or what type of stuff, but just to let them know these are the things to consider in the ARD. And if you have services that will address this specific symptom, that would be very helpful. And on my side, I'm giving him this medication, and this medication does X, Y, and Z. So between the two of us, we ought to be seeing if that's helpful for that child. The realistic expectations aren't going to be realistic if we don't have this kind of feeling of working together. And frequently, parents, in an understandable way, I haven't seen an evil parent yet, but certainly parents get frustrated, often angry, often do finger pointing, and the teacher, understandably feeling very frustrated, may point the finger back, and the next thing you know, you've got kind of disruption so that there really isn't this team approach to working on the kid. And sometimes the mental health providers are guilty of simply not providing the necessary information, and sometimes even sending a representative to help clarify what the issues are that are getting in the way of this behavior, and perhaps getting information from the school that would help us understand. We may be working with different information or working with misperceptions the parents have about what's going on in school, that if we knew the real information, that might have a bearing on what medications we choose or how we approach that kid and approach the parents. So I think as you're counseling your teachers and you're working with the parents in that situation, the idea of asking the parent to go back and if it's not clear in your mind what are the medications for, or how are we supposed to tell if they're working, and the parent says, well, I don't know, it's supposed to treat bipolar disorder. So it's clear that somehow there's been a disconnect in terms of what the parent remembers or what the doctor hasn't told them. And you can, I think, very reasonably say, look, what would be helpful for me is for you at your next visit with your provider, ask them specifically what the target symptoms are and how they expect that to help the child in the classroom. And then we'll work at this end to try to see and observe if that's in fact happening, and try to facilitate and support that child in seeing if we can get that to work. And I think that will help to educate the parent a little bit, get them to be making better use of both the school resources and the mental health resources, and it'll help bring kind of a team approach where necessary on especially the more severe children. The parent responsibility really is to get a written assessment and to share that. They say, well, I don't want to tell the teacher because that'll bias him or bias her. And I keep telling them, this isn't about biasing. This is about educating the teacher. And don't say, oh, well, he's got this disorder, so you need to treat him real special, and you shouldn't hold him responsible for this, that, and the other. That's not what they should be doing. But they should be either sharing a written assessment as to what the issues are, the problem list, medications, and keep from having all this distorted stuff where the teacher doesn't even know what's going on, and then the parent is really surprised when the teacher gets really exasperated or frustrated and sends the kid to the principal's office, or is not very empathetic with what's going on with the child because the teacher simply hasn't been read in. And if that's the case, frequently you, as the educational psychologist or counselor or whatever role you play, have the responsibility to make that clear to the parent that we want to help your child at the school, but we simply don't exactly know what's expected. We don't know about what's going on with this disorder, and it really helps us to know what the mental health provider is doing. Sometimes it may behoove you to call. I realize it's difficult to get anybody, either at school or in the mental health clinic, and sometimes you'll need to leave a message, but hopefully you'll have the courtesy extended back to you of somebody calling back and helping to compare notes with you and to share the assessment, evaluation plan, and what you're expecting from that, and an agreement as to what we'll do if this isn't working. This is something we may need to meet together and come up with a different plan. All these things speak to the interests of the child ultimately doing better, and the parents feeling more empowered and more involved to do the right thing by the child. Then this next to last slide about the teacher, counselor, school psychologist's responsibility. The things for the teacher to be, the teacher should be ready, and if the teacher hasn't been ready and the parents tell you, I don't want to tell the teacher about this, but I'll tell you, well, you can encourage them to share this with the teacher, but on the other hand, you can also take that information and say, look, I really got to talk to the teacher so that we're all ready in on all this. We're all working in the same direction. And in that case, then your responsibility is to make sure that the teacher is aware, and if the teacher is frustrated or the teacher says, I just don't know what to do when this kid does this, I got 29 other kids that are being kept from learning, and that's where your expertise and what you're learning now to consult in the classroom, but also to help the teacher better understand the condition and to discuss the target symptoms, target behaviors, and then also get information from the teacher so that you can have maybe a more rational discourse with the mental health provider and giving them information that he might not have. So it takes your responsibility to kind of bring some rationalness to the teacher, also explain to the mental health, and also in working with the parents. That's a big job, but I think that's ultimately the satisfaction and the reward that comes when that works out and the kid's doing better. And finally, understanding that the student's success, both in the classroom and really in the inference is that we really want the student to be functional socially with the environment, whether it's at home, in the classroom, with his peers, her peers. That's the ultimate goal. And sometimes we do get lost in fighting the good fight with our peers, with our fellow professionals in both directions, with the parents, because the parents sometimes can be excruciatingly either insulting or difficult. And what do you do at that point? We can throw up our hands and say, this is going to be a long year. Or perhaps we can work with others around us to see if we can get a better handle, get our arms around this child's difficulties. You've got some kids that basically you can do that all you want, and it's a uphill course all the way with multiple hospitalizations, this, that, and the other. But I also think there's a significant proportion of children that will respond to being better and better educated and clear and able to be clarified in terms of what the actual problems are, what the disorder is, what the mental health plan is, whether it's therapy, whether it's the medications, what the medication is supposed to do, and then working with the parents and the teacher. And I think that's the fun part about what your career is about to embark on. And I hope that's been helpful for you in terms of the use of psychotropic medications in the students in your schools. So I'm going to leave it at that. And Dr. Sullivan, I'm sorry if this took a long time to say. The nice thing about this being on digits is that you can just cut some of these digits out, and I will certainly understand. I'm looking forward to getting a chance to meet the folks in the class, and hope we'll have an opportunity to do so. Thanks. Goodbye.